I think we can start. Yeah, I think we can start, so we don't get late. This is Dr. Kusayir. I'll have the honor to moderate me and with Professor Rashad this PAVSS Journal Club. It gives me a great honor to welcome the panelists. We have Dr. Hassan Al-Thani from Qatar, Dr. Luay Tarazi, he will join us later on. He's from Syria, Dr. Paula Ortiz from Uruguay, and Dr. Musad Sulaiman from Egypt. We're going to discuss two great papers. The first one, I think, is a great effort from Professor Rashad group. I think, I'm not sure, but could be the first randomized control trial from Egypt or from the region. He's going to discuss, and the presenter will be Dr. Haroon. He's a vascular surgery resident at Mansoura International Hospital, Mansoura, Egypt. He's going to talk about efficacy of ultrasound-guided form sclerotherapy in the healing of venous leg ulcer. After that, Dr. Osama Al-Ahmadi, he's a consultant vascular endovascular surgeon, work at King Fahd Hospital, Medina in Saudi Arabia. He will going to discuss also a great paper, which could be a complementary to first paper. He's going to talk about the factor associated with delayed venous ulcer healing after endovascular intervention for superficial venous insufficiency, and I'll be moderating this paper. So, Professor Rashad, you can start, please.
Well, it's my great pleasure and honor to participate in the PAVSS Journal Club. This is really a great educational effort. And it's my pleasure to introduce Dr. Ahmed Assam Haroon. As you said, he's an ambitious young vascular surgeon from Mansoura University. And for those who don't know, Mansoura is one of our better universities with a lot of creativity and a lot of innovation. And Ahmed Haroon himself is a very, very ambitious, nice guy. So please go ahead, Dr. Haroon.
Thank you, Dr. Rashad. Thank you, our esteemed colleagues, for giving me the opportunity of being here. I'll just start by sharing my screen. Okay, can you see my slides?
Yes, go ahead.
Yes.
Thank you. Okay, good evening, esteemed colleagues. It's a real privilege to join you all today. My sincere thanks to our distinguished panelists whose work and experience I deeply admire. I'm especially grateful for Dr. Rashad Bishara and Dr. Samer Kusayir for their generous invitation and trust. Today, I'm honored to present this meaningful work by Dr. Bishara and colleagues, an important step in our shared inquiry into how we can improve healing for patients with venous leg ulcers. With that, let's begin. Okay, venous leg ulcers are not just chronic wounds. They mean pain, recurrence, dressings, immobility, and lost productivity. So faster healing is a meaningful clinical outcome. IVRA established the value of early axial reflux treatment, but this trial asks the next logical question. Should we also treat the refluxing venous network directly beneath the ulcer? It's JVS Venous and Lymphatic Disorders 2025 Open Access Prospective RCT. 6 Egyptian centers in collaboration with Imperial College London. Senior authorship includes Bishara in Cairo, Shalhoub at Imperial College, and Alan Davis as a senior advisor. The work was presented as a first place abstract winner at AVF Venus 2025 in Atlanta. The central concept is this: a VLU, or a venous leg ulcer, is a hemodynamic wound. Reflux or obstruction leads to ambulatory venous hypertension and microcirculatory injury, and then skin breakdown. The ulcer is visible on the surface, but the pressure problem is layered beneath it. Before this trial, compression was foundational. The Escher trial supported superficial reflux treatment for recurrence, and IVRA trial showed that early axial ablation accelerates healing. But the distal ulcer vein network remained the evidence gap. Cohorts suggested benefit, but randomized data were weak. The reason this trial was needed is simple. Guidelines acknowledged the concept, cohorts pointed towards benefit, but prior RCTs were either inconclusive or asked a different question. This study directly tests adjunctive ultrasound-guided foam sclerotherapy of the ulcer vein network. The objective was to test whether ultrasound-guided foam sclerotherapy of the distal refluxing venous network added to the standard care improves healing in active venous leg ulcers. The hypothesis was that selected patients with refluxing ulcer veins heal faster when the network is treated. PICO is clean here, population, adults with active venous leg ulcers and demonstrable refluxing ulcer veins with ankle brachial index at least 0.8 and ulcers under 20 centimeters and under 2 years old. Interventions were ultrasound-guided foam sclerotherapy of the distal ulcer vein network, and the comparator was the standard care alone, including compression, wound care, axial reflux ablation, and deep venous management when appropriate. The outcome we want to measure here is the time to complete healing as the main primary outcome, with multiple secondary outcomes that we will discuss later. So this is a prospective multi-center parallel group RCT with 1-to-1 randomization. Allocation was concealed until assignment, but after allocation, it was open label. This is important for appraisal, especially because healing assessment can still be influenced by knowledge of treatment. The study population was deliberately selected. There were not all ulcers. There were active VLUs with a demonstrable refluxing peri-ulcer network. Exclusions included significant arterial disease and very large ulcers, very chronic ulcers, and the absence of identifiable ulcer vein target. The intervention was technically defined: ultrasound-guided treatment of ulcer veins with or without perforators. As we see, perforators is not the main target here. Polydecanol foam with Tessari method, 5 to 10 milliliters per session, up to 2 sessions with compression immediately afterward and duplex at 1 week. So this is a reproducible protocol, not a vague intervention. This is one of the most important slides. Both groups received modern standard care, compression, wound care, debridement, or antibiotics when needed, superficial reflux ablation, and deep venous recanalization when appropriate. The trial isolates one added variable: ultrasound-guided foam sclerotherapy of the ulcer vein network. This is not foam versus nothing. 77 ulcers in 71 patients were randomized. The final analysis included 29 venous leg ulcers in the ultrasound-guided foam sclerotherapy arm and 36 in control arm. The key appraisal point is that this was available case analysis, not strict intention to treat, with more attrition in the ultrasound-guided foam sclerotherapy arm. The groups were broadly balanced, except for ulcer duration, 4 months in the ultrasound-guided foam sclerotherapy arm versus 6 months in control, with a p-value of 0.02. That matters because older ulcers may heal more slowly, but we're gonna address this later. The authors addressed this statistically, and the ultrasound-guided foam sclerotherapy remained significant, but this imbalance still belongs in our interpretation. Duplex finding and co-interventions were broadly similar. Both groups had refluxing ulcer veins by design, and both had comparable access to axial reflux ablation and deep venous treatment. The systemic difference was ultrasound-guided sclerotherapy for the ulcer vein network. Now, the main result. Median healing time was 35 days with ultrasound-guided foam sclerotherapy versus 56 days with standard care alone. And this is statistically significant and clinically significant. This is a 21-day median advantage with p-value of 0.008. This curve matters because it shows the story visually, early separation and significant faster healing in the ultrasound-guided foam sclerotherapy arm, but continued healing in the control arm. So the correct interpretation is acceleration, not rescue. Standard care worked, but ultrasound-guided foam sclerotherapy made healing faster, significantly faster in selected patients. The secondary outcomes this study tried to measure is supporting the same direction. At 3 months, healing was 97% versus 75% in the control arm with p-value of 0.01. By 6 months, both groups had high healing rates, 100% versus 92% reported descriptively. So again, the message is faster healing, not merely eventual healing. This ulcer size curve gives the wound-based view with ultrasound-guided reached mean closure around 120 days, while control closed much later. So, and venous clinical severity score improved in both groups without a significant between-group difference after treatment. No major ultrasound-guided foam sclerotherapy complications were reported. No anaphylaxis, neurological symptoms, visual symptoms, chest tightness, superficial vein thrombosis, or DVT. Reassuring, yes, but with 33 treated limbs, the trial is underpowered for rare events, so safety is encouraging, not definitive. The author's conclusion is balanced. Standard care improved both groups. Ultrasound-guided foam sclerotherapy shortened time to healing and improved early healing rate. They position ultrasound-guided foam sclerotherapy as an adjunct, not a replacement for compression, axial reflux treatment, and deep venous management. So my final appraisal here, the strengths are randomized. Randomized multi-center design and clinically meaningful endpoint and with modern comparator and coherent hemodynamic rationale and reproducible ultrasound-guided foam sclerotherapy protocol. Of course, with internationally respected senior authorship as Dr. Bishara, Davis, and Shalhoub. And as Dr. Samir just said, it's not a common thing to come from our region, like such impactful randomized control trial. So this was really a strength of this trial. So after those strengths and limitations, the real clinical question becomes, how do we apply this without overextending it? Clinically, this is a selective strategy. Ultrasound-guided foam sclerotherapy belongs after proper venous leg ulcer confirmation, arterial exclusion, Dopplex mapping, compression, wound care, and treatment of axial or deep venous disease. When indicated, the patient who benefits is the patient with a visible refluxing peri-ulcer network on Dopplex. So this is not routine foam for every ulcer. It's targeted treatment for the right anatomy. Perhaps the most important contribution of this paper is that it redirects our attention beneath the surface of the ulcer. In selected patients, the refluxing ulcer vein network is not just anatomy. It's a treatable hemodynamic target, and when treated thoughtfully with ultrasound-guided foam sclerotherapy, alongside modern standard care, healing appears to happen much faster. So thank you very much. I will stop here and hand the floor back to Dr. Bishara. Dr. Rashad, thank you again for your kind invitation and for this important work. It has been a privilege to present it, and I look forward to your thoughts and the discussion. Thank you.
Well, good job. You did a very nice presentation. Can you stop sharing, please? Stop sharing your slides. And I would like to invite the discussants if they have any comments or questions. But first of all, there are no questions from the audience. So to the audience, please put your questions in the Q&A box and we'll have them replied. Now, can I ask Dr. Paolo Ortiz to come in, and we would like to listen to your comments and questions, please.
Okay, so hello, good afternoon, everybody. And so thank you very much for the invitation. It is truly an honor to be here. And congratulations, the Pan-Arabic Surgical Society for this organization. It's truly really good and very interesting topics. So I want to congratulate as well Dr. Ahmed Essam, because it was really good presented, and also to Rashad, Bishara, and all the team, because this is really a good paper for everybody to have as a evidence-based information for our everyday treatment. I do a lot of ultrasound-guided foam sclerotherapy in our humanitarian activities in Honduras, over 2,000 patients, and I witnessed what you have presented here, that treating the bed ulcer with foam improve the healing process, and we have a lot of ulcer healed with this technique. And so thank you for preparing, for giving us this really important paper, because randomized control trials and meta-analysis are the best of our evidence. So thank you for the work. And I have a couple of questions for Dr. Ahmed, and about for example, how the technique. I'm interested to know exactly which vein do you inject below the ulcer. If you find a perforator, for example, are you going to directly to the perforator first, or going to any other veins below the ulcer? And also, I would like to know if you have the size of the perforators. So because maybe this can change the outcomes, and so I would like to know if you addressed or documented that. And another question, if you are going to follow up the patients for like 1 year, 2 years, and 3 years, so long term. And thank you for the opportunity. Really good job.
Thank you, Dr. Paula. I guess Dr. Rashad has the utmost expertise answering these questions, but I will start with the understanding I got from the paper. The perforator wasn't the main target itself. Whenever a perforator is one of the feeders of beneath the ulcer, it can be targeted, but it's not targeted as a standalone target. So we didn't have like a cutoff points for the size of perforator to manage. And I guess Dr. Rashad can elaborate on this more. And for the second question, there is a follow-up, a prolonged follow-up for the cohort of patients, and still pending publication for assessing the quality of life. It's mostly happens as on weekly basis, asking for recurrence and quality of life improvement. But this is going to be published later with standalone results. And I will give the floor to Dr. Bishara to elaborate more on these answers.
Thank you, Dr. Hanoun. Obviously, Paola, you are very experienced, so you asked a key question, and that's regarding the perforators. So the question is whether we targeted the perforators to obliterate them or not. And the answer is no, we did not. So the treatment was directed to the network of veins underlying the ulcer. Now, some of them had incompetent perforators, some didn't. We did not target the perforators. We injected the network of veins, and in most cases, the perforators obliterated. But if they were not obliterated, this was not actually our target. This is very important regarding the perforators. Now, the second question regarding long-term follow-up, we actually followed up those same patients for a minimum of 2 years for each patient. And we submitted our long-term results, and it was just published, yesterday. It's not published. I'm sorry, accepted yesterday. So it's going to be published very soon. Now there are quite a few questions in the Q&A, and I will go through them rapidly before we go to the other discussant. Any information regarding recurrence? Yes, there will be very detailed information in our second publication, but in 2 words, it seemed that ultrasound-guided foam sclerotherapy of the network of veins underlying the ulcer not only achieves a more rapid healing, but also it reduces recurrence. And this is the first intervention that has shown to reduce recurrence. A question from Dr. Mohammed Al Farouk, my colleague. He's asking about financial comparison. The financial comparison is that, of course, this was a randomized controlled trial, so there is no finance involved. None of the patient paid anything for the treatment. The treatment was given free of charge to all patients in both groups. But if you calculate the cost, there will be the cost, of course, of the sclerotherapy, which is minimal. The sclerotherapy is not expensive. Thank you, Dr. Hoballa, for saying the nice words. Dr. Ahmed Musa, did circumferential long-standing ulcers took place? No, they were not included because we did not want to include patients that will not achieve complete healing within the study periods. The study period was 24 months, and we wanted that all the patients achieve healing within the 24 months so that we can have two groups to compare their end results. Another question. Thank you for your understanding. I would ask our difference, the different drugs that were used. There were only one drug, which is polidocanol. How many of the patients with foam sclerotherapy of perforators had prior thermal ablation of the great saphenous vein system, and was there a difference in the healing between those who treated great saphenous vein tract and those without? Now, the two groups had standard treatment. So if a patient presented with great saphenous vein reflux, he would have great saphenous vein ablation or stripping according to the preference of the physician, but this is applied to both groups. Also, both groups had every other aspect of treatment of venous leg ulcer the same. So both groups had compression the same way. Both groups had ablation of the superficial reflux, and both groups had iliac vein recanalization. This was left to the treating physician. And the drug superior to another, there was only one drug used. How do you decide about concentration of sclerosant? It was standardized. So we used 0.5 to 1%. Probably most of the patients had 1%. So these were the Q&A. And I would like to go back to Dr. Paola Ortiz, if you like to have any more comments before we move to the second discussant.
No, I'm happy to have this paper now because address one important point about the ulcer healing, which is the network and the microcirculation hypertension. Because if we treat the superficial and the perforators, so we have still something to do in the microcirculation under the ulcers, and with this paper we can have now evidence that the physiology of the ulcer is all this network, all this pathway that's integrated into and impact into the microcirculation really below the ulcer. So thank you very much, and this is all what I have to say. Thank you.
Thank you, Paola, for your participation. Dr. Samer, who is the second discussant, please? Is it Dr. Lai or Dr. Tani or Dr. Mossad Suleiman?
Anyone we can discuss, we can talk to the panelists and see what your opinion about the paper, I just have a question really, is that are we moving to the, like in the arterial work, we start with the angial zone, then the wound zone. Are we in the venous, we're going to have the same like a wound zone? You think that we can concentrate on the venous reflex in the wound itself, not to look at the whole leg reflexes?
I was going to ask the second discussant exactly this question.
Okay,
so you just
let's give it to the panelists. Let them answer it.
Yeah, I'll rephrase it. So, Dr. Luai, I'm sure you do a lot of sclerotherapy. I know this, and I'm sure you treat a lot of venous leg ulcers. So, if you have a patient with venous leg ulcer and superficial reflux in the great saphenous vein, do you do the ulcer foam sclerotherapy first, or do you do the stripping or ablation first?
Thank you, Dr. Bishara. Sure. For our subject, the injection of the vein under the ulcer, we began together nearly 15 years ago with Dr. Taha, the discussion about it, and we are using it routinely now. Maybe the only difference is that we are insisting on the perforator. And for the venous ulcer, as we all know, it is just the tip of the iceberg. Donc there is mountains of problem under the venous ulcer always. It is not enough to treat just what we can see. Sure, we must study the patient on all aspects, from respiratory to cardiac to circulatory to immunology states, and do a cartography planning of pelvic deep veins, superficial veins, perforator, and microcirculation before to do anything. But for the question, if we really have a superficial vein reflux and venous ulcer, sure, we must treat first the reflux if we are convinced that the reflux is the real the real cause of the hypertension, venous hypertension. We couldn't begin with the ulcer directly. I know there is some teams that are going directly to the vein ulcers, but I think we must treat the origin and control the venous pressure before, and then not only and treating the underlying occlusion, etc. And after that, we will do this treatment. And we are always studying very well the perforator. And as you know, everyone is talking about perforator itself and the skin and the superficial vein. No one is speaking about the deep vein who is feeding this perforator. Why does it feed this perforator? Is a question. We must look for it. No one speaks about it normally. So I agree everything, and I begin with dealing with the superficial vein incontinence.
If I may comment back, I don't disagree with your policy. It's just for the logistic reasons. Injecting the ulcer is faster and inexpensive. So when I see a patient with venous leg ulcer, I do the injection first because it's easy and you can do it quickly, and then plan for the great saphenous vein ablation or iliac vein recanalization, because this usually need approval from the insurance company or approval from the patient himself, and this might take a week or 2 weeks. So they can start with the injection, which is fast and easy, and we have shown that you only need 1 session in most patients. So we can start with this, and then as soon as we get the approval or the agreement of the patient, we do the great saphenous vein reflux. And the same for the iliac vein occlusion. It has to be done, but it usually takes a procedure to be done. So we do the sclerotherapy just to gain time and to get the ulcer starting to heal until we do the rest. But I don't disagree with you. Yeah. Thank you. I think the time is over, Dr. Samer. Am I right for this presentation?
Yeah, but let's get some feedback from Dr. Musad and Dr. Hassan Tani. Dr. Musad, what do you think about this paper? Any questions?
Yes, I'm very happy to have you all together here to discuss one of the great works done by Dr. Rashad. Actually, I have a few comments from my end. First is about the use of the primary outcome and the secondary outcome, which is the time to ulcer healing, and the secondary outcome, which is the rate of ulcer healing, which I feel they are both interrelated. And in our usual work, we use the primary outcome as the efficacy of the material in use, and the secondary outcome we usually direct it toward the presence of any complications of the material, like on the counterpart on the arterial side. We use the primary outcome for the patency, and for the secondary outcome if there is a major adverse limb events or cardiovascular events. This is one about the outcome. And the other point is the inclusion criteria, which is the presence of reflux in the peri-ulcer area. So there are no many of us is using the duplex to assess the reflux in the peri-ulcer area. In the majority of reports we see, it is about the reflux in the major trunks, and sometimes they give us an idea about the perforators, but none of the reports we see is the reflux in the peri-ulcer area. So this needs a very sophisticated work. And of course, I understand Dr. Bishara has accompanying a team who's doing this great job. But what I can't see in the paper is how do you do it? Like how do you assess the reflux in the peri-ulcer area, like sourcing, swinging, and the manual compression, which is not clear in the article. But for the juniors who may be listening to us, it is a very a skillful way to assess the reflux by compression and releasing the compression and seeing the bidirectional flow and doing a manual compression to assess the flow in the refluxing area and to assess whether it is coming from below, from the underneath perforator, or coming from the axial trunks. This is a very skillful way, which I did miss in definition of the reflux in the peri-ulcer area. And the most important is that what I'm doing now in the era of the augmented visual reality, I used the augmented visual reality in supplanting the assessment of reflux in the peri-ulcer area. So I just see the peri-ulcer venules and telangiectasia, and I start working on them immediately while I'm doing the ablation. So I may not use the reflux at all. I'm thankful, of course, for Dr. Rashad to take the time to do this hard assessment. But actually, what I'm doing in this era of augmented reality, I look at the vessels around the ulcer and I inject them, I sclerose them, whatever they are refluxing or not, because I'm pretty sure they are a part of the pathology that is present in the peri-ulcer. And I have a publication in 2010 about the role of the sclerotherapy in the peri-ulcer area. And at that time, we didn't have the visual reality. One more thing is that they excluded an ulcer duration of more than 2 years, which in the main text of the study, they didn't find any correlation of healing time with the time of the ulcer, which is very surprising because this comes the question, why did we exclude an ulcer for 2 years? And as I have noticed in the second paper, they excluded ulcer for more years, for a time of 4 years. So if the time didn't correlate with the time of healing of the ulcer, so why we do exclusion for a long time ulcer? Another thing is in 45% in group A and 33% in group B, they had a previous venous intervention, which hasn't been shown in the study. Does this intervention was surgical or endovenous? And how does it comes in alignment with the original protocol? Did they do the same you are doing? They did a supragenicular or infragenicular, and this wasn't clear in the study. Another thing is that while you're doing an ablation of the axial reflux, this was performed in the supragenicular part in 10 patients of group A and 18 patients in group B. And what if the reflux is coming down to the base of the ulcer? So you still make quite enough intervention for the supragenicular part and you leave the lower part. While in a study by Lapropoulos, he reported in 2012 that if you have an axial reflux, it matters when the reflux is coming to the floor of the ulcer. So we have to ablate if the reflux is coming down to the base of the ulcer, we have to ablate this lower part with few tricks like cannulation the floor of the ulcer, or using RF, or using a laser 1940 with a minimal damage to the surrounding saphenous nerve. I totally admire the work that has been done, although the comments will give a clarity for the audience, especially for our trainees and juniors. And I'm glad to listen from Dr. Rashad or any of the co-chairpersons. Thank you.
And it needs another half an hour to answer all those points, but I'll try and
full
go.
session, you know.
Yeah, I will try and go through them briefly. Regarding duplex of the underlying network of vein underlying the ulcer, it's quite straightforward and simple. We sit the patient or we stand the patient, and we put the probe covered by something sterile over the ulcer, and we don't press in order not to cause pain. And then we press on the foot, not on the ulcer, on the foot. So there is no pain involved. And if you press on the foot and release the pressure, you can see reflux very obviously. That's regarding the duplex scan. Regarding the ulcer duration, we analyzed all the factors that all the variables, including the ulcer duration, using multiple regression analysis, and we found that ulcer duration in those two groups were not related to the time of complete ulcer healing. Now, we excluded those who had a very long ulcer duration of presentation that's greater than 2 years, because we know that those patients are going to take a long time to heal, and they will probably not reach the end point of the study within the duration of the study. And we wanted all the patients to reach the end point of the study during the duration of the study, so that we could have concrete results in terms of complete ulcer healing. Now, it can seem a little bit confusing, but if we admitted patient with greater than 2 years ulcer duration, there would be patients in group A and group B, and probably again the ulcer duration would not show statistical significance in the ulcer healing rates comparing the two groups. But of course, if we take a patient with a small ulcer and we take a patient with a very large ulcer, obviously the one with a very large ulcer will take a much longer time. But we are not comparing small ulcers with large ulcers. We are comparing a group which received ultrasound guided bronchial therapy to a group which did not receive. So we wanted to take out the extensive ulcer healing time by excluding those who had a very long ulcer duration. Now, regarding previous treatment, again, that's a randomized study. And when you randomize patients, you don't look whether they had what previous treatment they had. So previous treatment was one of the factors that was analyzed in the multiple regression analysis, and it was shown that it did not affect the time to ulcer healing. Finally, treatment of the below the knee tributaries or below the knee refluxing great saphenous vein. This was achieved equally in both groups. So both groups had ablation of the great saphenous vein above the knee, and they had treatment of the leg tributaries, incumbent tributaries, I mean, whether by ablation or by foam therapy or by phlebectomy. And this is according to the preference of the operator. I think I answered most of the questions.
Well, thank
Dr.
you.
Mossad. Thank you very much.
Thank you, Dr.
Okay.
Thank you.
Thank you, Professor. Thank you. Because the time, limiting, we need to move to the second case. Because
Sammy, is it okay if I just comment?
Yeah, please, go
Sorry,
ahead.
I know the time is high, but since you invite me, I have to comment.
Yeah, please. Yeah, go ahead, Dr. Hassan, please.
I would like actually first to thank you for the invitation and for the group for their excellent presentation regarding this randomized control trial. As you already mentioned, this is very difficult to establish randomized control trial in our region. So well done, Professor Bishara, for this randomized trial. I'm just going to go to, the finding that, I'm interested on. First, there is in the methodology maybe a type error regarding the percentage of the foam therapy, 0.5 to 110%. I think that needs to be corrected because that's something wrong. So the second element is actually this study, which was 2 years from 2022 January to 2023 December, collected a small number of patients, although being actually statistically addressed to have a limited error in the sample size. The group is divided not based on patient, but based on ulcers. So if we actually take the statistic for these ulcers, and each ulcer account for 3%, and therefore there is 6 ulcer which actually recurrent. And if you factor that, whether it is in group A or group B, then that's impact significantly in the statistic analysis and will change your results, because the 6 patient can be to 1 limbs, it will affect it, because after the randomization, that patient will receive the same treatment regardless of the ulcers, and therefore this will impact on your result. The degree of reflex on the system is not being discussed, although just mention the degree of reflex. There is, in terms of actually the discussion, there is some ambiguity in terms of actually the finding. I'm not going to go into that detail, but the main thing when actually come to the statistic again, the sample size and the interim actually analysis, which was stopped because there was 17% dropout or no follow-up in this study, whereas the calculated percentage to allow for the change in size is 10%. So there is 7% impact on the changes, and due to the fact that the conclusion stated that early ulcer healing is impacted by the ultrasound-guided foam therapy, need to be really taken in consideration very carefully to be analyzed before we come to that final conclusion. I was also interested because as stated in the beginning, the methodology, 6 centers, which are teaching center in Egypt, were involved. But when you actually check the affiliation, there was actually less than that in terms of a teaching. There is 2 private clinic, which Professor Bishara and the group is allocated. Is there actually patient allocated from the private clinic to this study? Because these type of patient may have a different way of a treatment compared to the patient who comes to a public hospital and a teaching hospital within this study. So I will be really interested to know about the statistic analysis when we convert this one to patient rather than ulcer, and how this will impact on the final result. Thank you, Professor Sami. Sorry to say that I just discussed. I know the time is running out, but
No, it's
I
okay.
don't
Thank
need
you
a
very
comment
much.
from this. So.
No, we need to get a comment from Dr. Bishara. Let him answer. It's okay.
Okay, well, thank you very much for having read the paper very carefully, and thank you for your very good questions. Now, regarding the sample size, before starting the study, we did statistical analysis to calculate the sample size that's required, and the sample size calculated was 130 patients. But we decided that in the interim, after we achieved half this number, which is 65 patients, we should do an analysis and see whether there is significant difference between the 2 groups or not. So when we reached the 65 patients, we did this analysis, and there was significant difference between the 2 groups. At this point, we could not continue to randomize patients because because we knew that ultrasound-guided foam therapy gives faster healing. So if we continue to randomize patients, it would be unethical to put patients into the no treatment group or the standard treatment group, because we know they will have worse results. So this is the 65 patients. That's the reason we have 65. But as I said, the statistical analysis showed significant difference between the 2 groups. Now, regarding the degree of reflux, whether it was mild or moderate or severe, the most recent guidelines suggest that it's not required to specify the amount of reflux, whether it's mild or moderate or severe, because there are many ways to quantitate the reflux. You could quantitate the reflux based on time or based on volume. or based on flow, and there is no consensus regarding how to measure reflux. So this is the reason it was either there is reflux or there is no reflux. But I could tell you that in most, if not all the patient, this was a continuous reflux. There was no valves. There was no valves. So if you press the foot and release, there was a continuous retrograde flow. So this was, all of them were severe reflux. Now, the last question regarding private clinic and university institutions. Well, there is no difference between the treatment received here and there. They all received standard treatment according to the treating physician. So actually, all the patient received the same treatment in terms of compression, ablation of superficial flux, and iliac vein canalization. Actually, iliac vein canalization was conducted in only one patient, so that did not make a difference. That's it. There is one question that I am missing, but I didn't understand. So I didn't understand it. So sorry about this. If you wish to repeat it, but I think time is running out. If you wish, we can discuss it in private. But I thank you very much for all your comments.
Thank you very much, really, Professor Bishara and Dr. Harun for this presentation. We can move to the next paper. Dr. Osama, can you share your slide, please?
Yes, sure. Okay. Assalamu alaikum. Thank you, the organizing committee and Dr. Sam Al-Qasai and Dr. Bishara for giving me the opportunity to discuss this in Journal Club.
I'm sorry if I could interrupt for just a quick second. We are seeing your slide sorter mode and not your presentation mode.
My slides are not in presentation mode?
Yeah, but the presentation mode, please.
Right, there you go. Yep.
Yes. Okay. So I'm going to talk about the factor associated with delayed venous ulcer healing after endovenous intervention for superficial venous insufficiency. So venous ulcers, approximately 1 to 2% of the adult population, and present advanced form of chronic venous disease. As we know, it's CEP class 6. They are characterized by prolonged healing time, a high recurrence rate, and significant impact on patient quality of life. Historically, this patient was managed with compression therapy alone, which is, as we know, that it had limited efficacy and slow healing and recurrence up to 70% over 5 years, which is mentioned in this study. There is a two trial, ISHAR trial and EVRA trial, that is compared between the compression therapy and the compression therapy with endovenous ablations that showed that that efficacy of the endovenous ablations and compression therapy both in healing of venous ulcers. So the venous ulcers, the venous ulcer in form of endothermal ablations and in the form of endovenous endothermal form sclerotherapy and evidence of very specific risk factors limited. Existing data regarding open surgical direct click explored to modern minimal invasive endovenous techniques that's now replacing the open surgical techniques. So the objectives and study design for this paper is to analyze the effect for diminished clinical and procedural variables on venous ulcer healing after endovenous ablation of insufficient superficial veins. Study design was the respective cohort study, and patient selection was 273 ulcers in patient in 259, including criteria including venous leg ulcers and superficial venous reflux pathological more than 0.5 seconds, treated with endovenous ablation. The exclusion criteria including the patient with peripheral arterial disease, non-venous ulcer etiology, and duration of the ulcers, more than 4 years. Baseline patient characteristics including the mean age and BMI, hypertension, atrial fibrillation, diabetes. Treatment protocol, as we all know, that treatment of venous ulcers, including three main categories in compression therapy and surgical and endovenous ablation. Endovenous ablation in the term of foam sclerotherapy or endothermal ablations, in term of radiofrequency ablation and endovenous laser ablations. And last thing that compression therapy, as we all know, that class 2 compression therapy. Coming now to the definition of delayed healing and follow-up protocol. When we say that this venous ulcer is delayed in healing, it is mentioned that it is typically 2 to 4 months after the first treatment modality for the venous ulcers. Follow-up protocols, monthly visits every 4 to 6 weeks at the vascular outpatient clinic. Each visit contain local wound debridement, duplex ultrasound, and additional endovenous treatment or superficial insufficiency. Variables assist in these studies, including demographic, ulcer characteristics, procedural venous in terms of grade stiffness reflux, short stiffness reflux, comorbidities, history and functional status of the patients, and history and functional status of the patient, ability to move or bedbound patients. Now here's the analysis factors that associated with delayed wound healing. Multivariate logistic regression include 5 significant variables: persistent superficial venous reflux after ablations, and recanalization treated segment, short stiffness reflux, history of DVT, wheelchair, ambulatory. Conclusion: after adjusting for confiders, persistent superficial vein reflux after ablation was the only independent predictor for delayed venous leg ulcer healing. Persistent reflux that mentioned in this study, all 19 patients with persistent reflux eventually achieved complete ulcer healing. Etiology of the persistent superficial reflux. Here we have mentioned our five more common etiologies for the persistent mixed reflux segment during the initial assessment, and that's why we have to mention that in the assessment we have to assess all the venous mapping system, including surface junction, short stiffness, and perforators, and also the deep system. Incomplete treatment in prior sessions, new reflux development, venous functioning normally, and at initial examination may develop reflux at subsequent visits. Recanalization, which is one of the factors also, a complex anatomy, tortuous vein, perforator incompetence, and short stiffness vein involvement. The pathophysiological consequences of the venous ulcers, as we all know, that is the venous stasis and hypertension that causing the ulcers. Short stiffness reflux, DVT history, and immobility, secondary risk factors. As we know that non-ambulatory status wheelchair patients, we are losing the bump of the muscles and that patient, so it will delay the venous return, and also causing the more effect on ulcers. Here's the endovenous ablation appears to neutralize several risk factors that compression therapy failed to do. As we see, the risk factors here is advances of the age, ulcer duration, recurrent ulcer, and ulcer diameters. We can see the first column under compression therapy, there is significant negative impactor and also strongly negative on the healing of the ulcer. But after endovenous ablation, it neutralizes these risk factors that can achieve a better healing for the ulcers. By addressing the underlying hemodynamic causes, superficial venous reflux, endovenous ablation creates more favorable healing environment that overrides many patient-level risk factors. This supports the use of endovenous ablation in elderly patients and those with long-standing or recurrent ulcers. Current practice gap: most vascular centers adapt to single treatment approach for venous leg ulcers. Evidence supporting regular follow-up, this mentioned. Study limitation: it's retrospective design, the data collected respectively over 10 years, and a single center study, and also the population, only 24 ulcers, 24 patients has ulcers. Clinical conclusion and practice recommendation. Key conclusion, persistent superficial venous reflux after endovenous ablation is the strongest independent predictor of delayed venous leg ulcer healing, reducing healing probability by 87%. Recanalization, short surface venous reflux, DVT history, and immobility are additional negative prognostic factors in ELEVATE analysis. Endovenous ablation overcome the traditional risk factors, as we mentioned in the previous table, age, ulcer duration, recurrence, and size. Practice recommendation, perform regular duplex ultrasound follow-up 4 to 6 weeks, this including the patient that have venous leg ulcers only. Actively identify and treat residual or recurrent superficial reflux in each follow-up visit. Do not withhold endovenous treatment based on age, ulcer chronicity, or prior ulcer. Consider repeat ablation early when the persistent reflux is detected rather than waiting for spontaneous healing. This is the study brief. The 3 take-home messages for clinical practice. Treat the reflux completely. Incomplete ablation is the primary enemy for ulcer healing. Ensure through ultrasound mapping and adequate energy form delivery. Follow up regularly with duplex ultrasound. Persistent flux may not be clinically apparent without imaging. Structured follow-up is essential to identify and retreat residual disease. Thank you for your attention.
Thank you, Usama. Thank you. Very nice presentation. Really appreciate that. So what do you think, Usama, about this paper? It's a good paper? It's a bad paper? What do you think? Is the conclusion is reasonable?
Yes, I think Dr. Samer, yes, it's reasonable because as mentioned in this paper, most of the centers relying on treating the venous reflux primarily, then missing the follow-up of the patient if the patient still have a persistent leg ulcers. So in the conclusion, we need to keep an eye on this patient, repeat the ultrasound, try to treat persistent reflux. Be aware that this patient, even after endovenous ablation, they have a chance they get recanalized, they get perforators, and they have again a reflux that was not treated the first time.
All right. Thank you very much. I mean, of course, it's a good paper, but has a lot of limitation. First, it's a retrospective, different from Dr. Bishara paper, which is randomized controlled trials. It's a single center. This is also may affect your outcome. We don't have standardized wound care protocol, which may affect the wound healing a lot. We know the wound healing is multifactorial, so not only the reflex affected. So not having the wound care protocol may affect your result. And the second thing also, the BMI cut off more than 35, it may affect it. Well, I don't know why they put a cut off. Usually should put it in different BMI because we know BMI affect the wound venous ulcer healing. And of course, we don't have no control group. But anyway, I don't want to take too much time. I'd like to leave the panelists give us their impression about this one. But first, we start Dr. Bishara. A question for you: if you think patient has not, you treat the reflux and he did not heal, do you think in this paper they miss your part, or they should look for the, for reflux around the ulcer bed? Maybe it's good. This is a reason.
Absolutely.
Okay, so your paper will be very complementary to this paper, I think, right?
Yes, sure.
This will be your next step, not only to look for reflux in the main vein, but to look at around the wound base,
Yeah.
All right.
Yeah.
Any comment, Dr. Bishara, before I go to panelist?
No, I think you made all the important comments, and I think the author missed out on injecting around the ulcer, which I think makes a lot of difference. So if I have a patient with, for example, iliac vein occlusion, great saphenous vein reflux, and the venous leg ulcer, I would surely do the iliac vein occlusion and ablate the great saphenous vein reflux, but I will not miss injecting around the ulcer because we have shown in our second publication that not only it makes the ulcer heals rapidly, but also it reduces recurrence, which makes a lot of sense. So I think this is an important message.
I think we are getting very close to the arterial system, right, Dr. Bishara? If you treat the SFA, popliteal, and iliac, and it's still no flow to the foot, to the wound will never heal. So I think we have to look at the base of the wound. That's the thing. We have to have a consent, like a wound zone in the venous system, say what we have in our arterial system. Maybe this something concept comes in the future. Yeah. Dr. Hassan Al-Thani, I'll give you the privilege to start. Dr. Hassan, what do you think?
Thank you. Well, you already mentioned this is a retrospective study. The thing that actually strike me compared to Professor Bishara paper is the age difference. You know, this is a geriatric age group, or sorry, an elder age group. You know, it is a 71 years old plus or minus 14. So we're talking about, you know, really old individuals here. And the multivariate analysis, strikingly, you know, put a wheelchair. I would rather want to see if they actually did calculate the frailty index for these patients. And that would reflect much better because these are a group of elder patients which can impact on this. So it is a retrospective study, as you said, something that we can learn from it, that treat the disease as a whole, and that will impact on of course, recurrence and the healing process. But thank you again for the invitation. I think there is a contrast between the two, and the two complement each other.
Thank you. Dr. Paula, do you follow up your patient after venous ablation? Do you have like a protocol to follow them to look for this recurrence
Yes.
of the reflex? What's your protocol?
Yes. So first, I'm agreeing with all of what you have said about the papers, retrospective and everything. And it is also important because ulcer is not easy, you know, to heal. Sometimes there are a lot of factors that influence. First of all, is to do the first thing begins with a good diagnosis. So we have to do a really good ultrasound and examination, hemodynamic examination of the patients in order to treat the reflux, the great saphenous vein, or small or anterior accessory veins, the perforator, so to treat everything, because otherwise we will have not faster healing. And then after treatment, I like to treat everything at once, like the great for the axial reflux, the perforators, and below the ulcers, as Dr. Bishara showed in his study. And I follow the patient 1 week for the complications, heat, and then I follow 1 month and 3 months to see the ulcers, and at 1 year. This is my follow-up with the ultrasound, but it's important to treat all the refluxing veins at the beginning in order to see, because sometimes we have combined reflux. When the patient has a C4, C5, and C6, we have to think, but it is not only one venous vein, also one vein refluxing. Most of the time it's a combined reflux patterns we have in those patients. So if we have an anterior accessory vein, we have to see if this vein is refluxing, because we have to treat this vein as well, and to do a very good technique, because recurrences or failure in healing depend of the technique we are doing, depends of the diagnosis, and depend of the patient's disease as well, you know, some other thing that can be involved, like arterial problems. But this is my protocol, and to think the hemodynamic from the beginning, and in each follow-up as well. So after, in my follow-up, I go again through all the veins, and I look for reflux in the superficial, and also perforators or another veins of the patient.
Thank you very much. Thank you very much. Very appreciated. Dr. Luai, what do you think about this paper? And the question for you really, if patient has a deep venous, reflux, and the ulcer is not healing, how we deal with that?
For the paper, it is a nice retrospective paper. I can say nothing about. But with the deep vein problem, we have always choices. We have to define our priorities. As Dr. Paula has said, we must treat everything. Okay, but what is the priority? What is the most influencing factor? Is it occlusion? Is it reflux? Is it the perforator? Is it sedentary life, etc.? And it is sometimes difficult to define. Sure, for the iliac vein occlusion, sometimes it is useless to open them. They are well compensated. And sometimes we open them and we have a direct reflux from the vena cava to the calf. So we worsen the case. So we must estimate these things.
So how you decide that? It's a very good concept. You know, I never thought
Yes,
about it. So how you decide
yes,
to treat it or not? Because you also
yes.
like to treat it. We thought this will help.
Okay. And also the same thing for the occlusion of the deep veins, the post-phlebitic syndrome. We have a lot of occlusion of the deep veins. It's the same thing. We must define where is our priority. Normally, in the past, we have a very good specialist of plethysmography, and it was a very nice. I know it is not a trend now, but it is a very good test. And so now we are trying to compensate its absence. And for those patients, we must know, is it occlusion or is it reflux? We are doing some tests first. First, the tourniquet or pneumatic calf on the site test. We inflate it till occluded only the superficial vein, and ask the patient to walk a little and see if he's ameliorated. And otherwise, it is measuring the venous pressure. It can be invasive or non-invasive. Invasive, just puncturing the lower saphenous anterne or dorsal vein. And non-invasive, it is by Doppler, by the cuff and the Doppler. And we can see, example, see you have the main pressure with the standing and with lying position, then you have an occlusion, sure. It is not the reflux that are, and if you have, yes, and if you have a rapid, when we opened calf, when we have a rapid progression of the pressure, it is a reflux. It is a reflux. So we can, but it is always a strategy how to do first and see.
Thank you very much. Dr. Mus'ab Sulaiman, what do you think about this paper? And do you have any comments?
Yes. First, it's not the factor that it is a retrospective. This doesn't matter for me at all. You sometimes you may see a retrospective study that worse everything with high score. Now I'm reviewing a retrospective study for the Journal of Innovation, and I just commented this is a great paper that needs publication without any change, and it's been around the robotic assisted skeletonization of the lymph nodes in the para-aortic area. And retrospective is not always a bad impact on the paper when it has robust structures around. But the comments I'm concerned about is, first, the study is lacking for definitions. Many definitions are needed to be visualized in the introductory part of the study. So first, why you didn't differentiate between recanalization and recurrence? What is the main landmarks to differentiate between a recanalization and a recurrence? Because they assessed the patients at 4 to 6 weeks post-operative. At this time, you cannot differentiate whether this was a primary failure of the intervention or it is a recanalization, because you already missed the part that can differentiate. If you assess the patient in the immediate intervention period, like second day or the day after, you may detect that there is a primary failure of your intervention. So this means a failure of therapy. But when you assess all the patients at 4 to 6 weeks, you cannot differentiate whether this is a primary failure of your intervention that needs a correction or it is a recanalization process. The other thing is they have introduced is using the 2 centimeter distance during the ablation, which is now being totally changed because there are many studies that recommend the flush ablation. And one of these studies that has discussed this part is a study by my group about it's a randomized controlled trial in the Journal of Endovascular Therapy. And it compared the flush therapy with a segmental therapy leaving 2 centimeter. And we have a very low rate of recurrence following the flush therapy because you ablate the inguinal refluxing veins from inducing recanalization. This is a very important part. Third part, they have insisted on the 10 milliliter use of sclerosant material. How can you do a total ablation of a long saphenous vein, which is around 1.5 centimeter diameter and 70 centimeter length with 10 milliliter? And actually, in my practice, I use 10, 15, and up to 20 milliliter of the same sclerosant they are using. I don't have any problem with that, because if you are aware of doing the interspacing between the doses, it's like any other sclerosant. You just give a time between every bolus you give and wait for 5 minutes, and then you give the bolus, the next bolus. This is a very simple trick you can use in your practice. Last thing is that they again excluded patients with a large ulcer more than 25 centimeter and for a duration of 4 years without any excuse. I don't understand why you are excluding patients with a 4-year ulcer. They are more sufferers. You have to give them a more chance, a more concise therapy, and you don't have to exclude them from any other stuff. Thank you.
Thank you, Musad. I'll try to answer a couple of your questions. First, for retrospective, I agree. Some retrospective studies are very good, but we have to remember that retrospective has its limitations. We have no control on the protocol. Regarding the early and late recurrence, why they make a difference? It would be the same treatment. Why does it make a difference if it's an early or late recurrence, recanalization or failure? You're going to treat him again, right? So why does it make a difference for you to know?
Let me tell you, if I found a patient after 6 months with a recanalization of the saphenous vein that I already ablated with endovenous intervention, and I found by this time many of the ulcers have already healed. So it is not the reflux that matters at this time. It's exactly like doing an angioplasty for a patient with a wound ulcer. And when you did the angioplasty, you have the ulcer healed. And afterwards, you find that your angioplasty have failed, and this is occlusion of the vessel, although the effect is still there, and the ulcer is already healed. So you don't do any intervention because you have targeted therapy, you have the ulcer healed, so you don't have to tackle the reflux once more. And I can see this in too many of my patients. I found there is still some reflux, but the ulcer already healed. So I don't tackle the patient anymore. I
see. For the 2 centimeter protocol, I think they have to follow it because this is by the company, the protocol, you have to stay 2 centimeters, I think the reason why they use 2 centimeters. But then sclerotherapy amount, I agree with you. Right, sorry.
It's even a recommendation by the European Society. I understand that, but I mean the real life practice. I use it in not only in the peri-ulcer area or a foam sclerotherapy for the tributaries in the limbs, but I use it also in a more proximal situations. I use it in pelvic congestion syndrome after coiling. I use the sandwich technique, and I use a lot of amount of sclerosant until I have a total ablation of the pelvic congestion, which is in real practice, it is closer to the central circulation than ablating in a limb. And you cannot compress, but in the limb you can compress, and you can slow down the reflux flow of the sclerosant material. I can do a compression, I can do a tourniquet. So I don't understand why they are insisting on a 10 milliliter, and I am sure you cannot fill a long saphenous vein with only 10 milliliter because the volume is a huge amount. The volume is 1 centimeter diameter or even more, and 70 centimeter length of the saphenous vein. You cannot totally occlude this vein with a 10 milliliter.
Okay, thank you very much for the time limited. Any question from any more comment from the panelists or anybody else before we finish? Okay, I think to summarize the 2 papers today, that is very important to look at for the reflux, either from the main, superficial venous system or around the ulcers. So I think the reflux is one of the most important. Yeah, go ahead. Sorry. Dr. Paola?
No, I didn't say anything.
Sorry. So any word at the end? You want to give us your last comment? You finish? What do you think about the reflux? I think what these two papers, just to emphasize the importance of treating the reflux either around the ulcer or in the main superficial venous system or even deep venous system. Is correct?
Sorry, the question was for me?
No, we're just saying the comment.
No,
the final comment. Yeah.
Yes, no, I think that here we have addresses the most important part of a treatment of the ulcer, which is the reflux, and the I support that treating the microcirculation, treating this reflux below the ulcer is really important. I witnessed this in our activities in humanitarian. We assisted 2,000 patients with foam, big gray saphenous vein, and sometimes the veins is not closed like the doctor said. We inject 10 cc, it may be not enough to close the vein, the gray saphenous vein or small, but even though the ulcer healed, because we decreases the hypertension if we do as well foam below the ulcer. So I do this when I have only foam for patients. I treat the gray saphenous vein, and I know that it will be not close in the follow-up, but treating also below the ulcers or the perforators or tributaries below will help a lot. And I can see this because the ulcer is healed and sometimes the gray saphenous vein is still open. Of course, this patient needs more treatment. We have to close all the refluxes vein related to the ulcer, the gray saphenous vein if it is involved, and also the perforators. And also, it's not only the reflux, but also a lot of things that we have to take in consideration. If the wound care as well, the compression, we have to insist in compression because it's not easy at all. We have to be on top of the patient. Follow up with the ultrasound, as I told you, but I follow up the patient very closely because we have to be very supportive to the patient to tolerate the compression and everything. So we treat the reflux, but we have to be sure that they are wearing the compression and also having a good ulcer wound care, and also to walk properly, because sometimes the calf is really important. I have a lot of ulcers that this doesn't heal because the calf is not, they don't, because they have pain and they walk without a really good movement of the leg, and the problem is the calf. We have the reflux, okay, everything treated, but the ulcer is not healing sometimes because the calf is not working, because they are not walking properly. It's just small things that we have to take everything in consideration in order to have a good result at the end for a good healing and no recurrence. So I think we have a lot of things to say about ulcers. Thank you for the opportunity.
Okay, no problem. I think we cannot cover it in one session. No question. As you said, the multifactorial, we need 10 sessions to venous ulcers, But it's give a treat to thanks panelists and speakers and moderators for this meeting. Thank you very much, guys, and happy Eid.
Thank you.
Thank you very much. Thank you.
Thank you.
Thank you, Dr. Saber. Thank you, everyone.
Thank you, guys.
Thank
you,
you
everyone.
Very much.
Bye-bye.
Thank you.
Bye-bye.
Bye.